Good evening, everybody. I would like to thank the organizers for giving me this opportunity. We have a few important topics to talk about the role of immunotherapy, in particularly pembrolizumab in both early as well as metastatic breast cancer. So first, we're going to talk about the Keynote 522 studies. The first presentation was of the ESMO presentation by Peter Smith, declaring the initial results of the role of neoadjuvant pembrolizumab with chemotherapy versus placebo with chemotherapy, followed by adjuvant uh, pembrolizumab in early stage triple negative breast cancer. And then subsequently, a further update presented at the San Antonio of last year, looking at event-free survival based on certain sensitivities and subgroup analysis. So I've combined both the abstracts together so that it makes some clinical relevance for our listeners and for us to take back to clinical practice. So this was the Keynote 532 study design where patients with early breast cancer who had triple negative disease, both stage 2 and 3, triple negative breast cancers were included above the age of 18 years with a good performance status, and tissue were available for PD-1 assessment. In the neoadjuvant stage, patients received carboplatin and paclitaxel, followed by anthracycline and cyclophosphamide, along with concurrent pembrolizumab, and the comparator arm was placebo along with chemotherapy. The randomization was 2:1 randomization in favor of the immunochemotherapy arm. Following the neoadjuvant phase, patient underwent surgery, followed by further 9 cycles of pembrolizumab versus placebo. Patients were stratified based on their nodal status, tumor size, as well as carboplatin scheduled whether they were given 3 weekly or weekly. The study endpoints were the primary endpoints were pathological complete response rates, as evaluated by local pathologist in intention to treat population, as well as event-free survival in the intention to treat population. There were various other secondary and exploratory endpoints. The statistical consideration was that the primary hypothesis need to have been met, which is pathological complete response as well as event-free survival benefit. And once they were met, the overall survival could then be evaluated. About 1,174 patients were recruited in this study. As you can see, from both the arms were reasonably well balanced in terms of PD-1 positivity rate, carboplatin scheduled tumor size, as well as nodal. The initial presentation was done at about 600 odd patients, and we can see that the complete pathological response was significantly in favor of those patients who received pembro along with chemo, as opposed to a placebo along with chemotherapy, with a 13.5 delta. So 64.8% had complete pathological response in the chemo-immuno arm, as opposed to 51% in the placebo chemotherapy arm, with a highly statistically significant p-value. And the initial event-free analysis of the 600 patients showed that the benefit was seen in those patients who received pembro with chemo as opposed to placebo with chemo, in terms of the number of events occurred, with a hazard ratio of 0.63, which was statistically significant. The primary event-free survival, including all the patients, kind of kept the same thing going on, as there was statistically significant benefit in those patients who received pembro along with chemo as opposed to placebo and chemo. So 84.5% event-free at 36 months if they received immunotherapy, as opposed to 76.8, in a highly statistically significant p-value. In the San Antonio, Peter Smith again evaluated different event endpoints. So event-free survival, the primary event-free survival looked at local progressive disease, local recurrence, distant progressive disease, distant recurrent, death from any cause, positive margins at last surgery, as well as non-breast primary. But they also evaluated other parameters such as new anti-cancer therapy for metastatic disease, second primary breast cancer, or if they included those patients who had positive margins at last surgery. So the various the definition of event-free survival was changed, looking at various other parameters. And when they took into consideration all of those different definitions of event-free survival, the outcome did not change. This kind of demonstrates the robustness of the event-free survival. That irrespective of constantly changing event-free survival definitions, the benefits were seen across all of those definitions. So that kind of gives us a good indicated that irrespective of the definition, the event-free survival was seen. When we look at the various subgroups based on which patients are stratified, looking at neural status, disease status, menopausal status, as well as definitions of HER2 and LDH, the benefits were seen across all subgroups. Because there was benefit in pathological complete response as well as event-free survival, the overall survival was evaluated. Though it is still early days, only about 3 years of follow-up, the numerical benefit is there, but not statistically significant yet, and I think further follow-up is required to give us the overall survival outcomes, and that will be presented in due course. One of the other parameters to look at was those patients who develop complete pathological response on chemotherapy or neoadjuvant chemotherapy. Now, this group of patients was split into those patients who had developed pathological complete response versus those who did not have complete pathological response. And when we look at those patients who developed complete pathological response, the benefit was seen. About 2% benefit was seen from 92.5 to 94.5. So small benefit numerically, but when we look at those patients who did not receive complete pathological response, the benefit was strikingly better. About 11% benefit was seen. So those patients who did not develop complete pathological response but ended up having immunotherapy, the event-free survival was about 67% as opposed to 56%. When you look at the treatment-related adverse events, the toxicity was not much more in the immunotherapy arm as opposed to the placebo arm of any grade or grade 3 and 4. However, there was slightly more discontinuation in the chemoimmune arm as opposed to the placebo chemo arm. So 27.7% discontinued because if they were in the chemoimmune arm as opposed to only 14% in the placebo chemotherapy arm. When we look at immune-mediated adverse events, there were slightly more reactions in the pembro chemo arm as opposed to the placebo chemo arm. And when we look at the discontinuation, about 10% discontinued treatment because of immune-mediated adverse events in the pembro chemo arm as opposed to only 2% in the placebo chemotherapy. So to summarize the Keynote 522 study, it was the first prospectively randomized study looking at the role of pembrolizumab in early triple-negative breast cancer at stage 2 and stage 3, and the study met both its primary endpoints, which was better complete pathological response rates as well as improvement in event-free survival. Pre-specified event-free survival sensitivity analysis, depending upon the changing parameters of what EFS was defined as, showed a robust treatment benefit across all of those definitions, and safety was consistent with the known profiles of those diseases. No new other safety concerns. When we look at regulatory approvals, the FDA and EMA have both approved the use of neoadjuvant pembrolizumab as well as adjuvant pembrolizumab. We are waiting for DCGS to come up with a verdict, and NICE has currently paused its evaluation based on the review analysis of cost-benefit evaluation. When we look at the guidelines, NCCN has clearly incorporated this as one of the approved regimes in triple-negative breast cancer. Looking at the other two abstracts, which was the Keynote 355 study, this was presented by Professor Rugo, which was the final results from the randomized double-blind phase 3 study of first-line pembro and chemo versus placebo and chemo in metastatic triple-negative breast cancer. And Javier Cortes further presented this in San Antonio, looking at the outcomes in different CPS scoring PD-1 positivity results, such as 1 to 9%, 10 to 19%, and more than 20%, which was the ad hoc subgroup analysis. So again, I've combined both of these abstracts together to make some clinical relevance for us clinicians. So this was the Keynote 355 study design. This was done in those patients who had metastatic triple-negative breast cancer with a good performance status, life expectancy of more than 12 weeks, age more than 18 years, and there was central determination of the triple-negative status as well as PD-1 expression. This was also a 2:1 randomization in favor of pembrolizumab plus chemotherapy versus placebo plus chemotherapy, and pembro or placebo was continued till disease progression or cessation of study therapy. Patients were stratified based on the type of chemotherapy received. So there are two types of chemotherapy that were allowed: a taxane or a gem carbo combination, PD-L1 expression of more than 1% or less than 1%, and prior treatment with the same class of chemotherapy in the neoadjuvant or adjuvant setting. Study endpoints, the dual primary endpoints were progression-free survival as well as overall survival in those patients with PD-L1 positive tumors with a CPS scoring of more than 10 as well as CPS of more than 1 in both progression-free survival as well as overall survival outcomes. Various other secondary endpoints were also evaluated. When we look at the statistical consideration, the overall survival superiority was evaluated first in those patients who had a CPS of more than 10%. And if that was true, then it was evaluated in those patients with a CPS of more than 1%, and then to intention to treat population. 847 patients were recruited in this study, and you can see that both the arms were well balanced. Pembro plus chemo versus placebo plus chemo, both well balanced across various parameters such as PD-L1 positivity, cut performance status, type of chemotherapy received, as well as disease-free interval from initial diagnosis, whether they were de novo metastasis, less than 12 months or more than 12 months of disease-free interval. The overall survival, looking at those patients who had a CPS of more than 10, which was the primary endpoint, was statistically significantly favor of those patients who received pembro plus chemo as opposed to placebo plus chemo. So 23 months for those patients who received pembro plus chemotherapy versus 16 months for those patients who received placebo plus chemotherapy. This resulted in a hazard ratio of 0.73, which was highly statistically significant. So this was the first graph, which was with CPS of more than 10. However, when you start looking at those patients with CPS more than 1 as well as intention to treat population, the benefit was numerically there, but statistical significance was no longer maintained. As you can see, the confidence interval was crossing unity in both the groups with the CPS of more than 1 and more than all intention to treat population. So one could interpret that CPS more than 10 was swing the Kaplan-Meier curves in favor of the chemo immuno. Javier Cortez subsequently presented in San Antonio the other CPS scoring types. So the CPS less than 1 and more than 20 were pre-specified, whereas PD-L1 CPS of 1 to 9 and 10 to 19 were exploratory. And you can see consistency that in those patients with a CPS of less than 1 or 1 to 9, the benefit was not there, but it started to become more prominent once the CPS crossed more than 10. So 10 to 19 as well as more than 20, the benefit was seen in favor of those patients who received pembro plus chemo as opposed to placebo plus chemotherapy. When we look at the progression-free survival, we see the benefit in favor of chemo immuno across all groups of PD-L1 expression, whether it is more than 10%, more than 1%, as well as intention to treat population. They were all statistically significant, but varying hazard ratio of 0.66, 0.75, and 0.82, depending upon the PD-L1 CPS score. Again, when we look at the subgroup analysis presented in San Antonio, less than 1% no benefit, 1 to 9% are starting to have some benefit, 10 to 19 and more than 20 incremental benefits were seen with higher the CPS scoring in favor of those patients who received pembro plus chemotherapy. In terms of treatment-related adverse events, again, nothing unusual to present here. There were more patients who led to drug discontinuation in the pembro plus chemo arm as opposed to placebo plus chemo arm, but no untoward effects were noted that we were not already aware of. When you look at immune-mediated adverse events, more immune-mediated adverse events were seen in those patients who received pembro as opposed to those who received placebo. But the discontinuation was only 2.8% of the patients in this situation, which was quite encouraging to see. So to summarize, pembro plus chemo resulted in statistically significant clinically meaningful improvements in PFS as well as OS, particularly in those patients who had a CPS scoring of more than 10%, and more than 10% CPS seems to be a reasonable cutoff to define the population who may be enriched with PD-L1. Safety was again consistent with known profiles of these regimes. When we look at regulatory guidelines and approvals, again, this has been approved by FDA and EMA in the metastatic setting. We're waiting for DCGA to come up with a verdict, and NICE is currently not yet started evaluating this. It is now a part of NCCN guidelines to consider pembrolizumab plus chemotherapy in those patients who got PD-1 positivity CPS scoring of more than 10%. So that is it from me. Thank you very much.